All right. Thank you, everybody, for joining us. We're excited to have with us Kate Hill from the compliance team. Kate brings a wealth of knowledge and experience in navigating complex regulatory environments. In today's session, Kate will be sharing valuable insights and guide us through a comprehensive review of the latest rule changes affecting RHCs. She'll provide a clear overview of the most common deficiencies cited during surveys, and most importantly, share practical strategies for how to avoid these pitfalls in your own clinic. Whether you're new to RHC operations or you're seasoned professional, today's session is designed to give you the clarity, tools, and confidence to strengthen your clinic's compliance efforts and better serve your community. Let's get started, Kate. The floor is yours.
Okay, thank you so much, Melissa, and I'm happy to be here. I'm going to turn my camera off so that you're not distracted by that. I find that's easier. So let's roll with what we're going to do today. First, we're going to review the new rules. Then we're going to review common deficiencies, and of course, learn how to avoid those deficiencies. You can do it. I know you can do it. So what's new this year? Mental health providers can see patients in the clinic alone. Now, this is a real curiosity. When they added the new mental health providers, they put it in 491 where they can be the only person seeing patients. So you must be certain that they can handle a medical emergency. And what does your emergency services policy say about that? So they cannot administer drugs. They should be CPR trained. That's the compliance team rule, but are they? And so you need to know that because it could happen, especially with no other medical provider in the building. And you must have some primary care. So this is allowing for specialists of any type to be in your clinic. Now, this is where you need to go to Elizabeth Burrows to find out who's going to pay us for what. So you don't just bring in an orthopedic surgeon and expect those drugs for joint injections are going to get paid, because they aren't. And that's not my expertise, but you can have any specialist you want as long as you get paid, of course. And it doesn't matter if you only have 2% primary care. That's what the law changed, outpatient health services. Now, what didn't change and breaks my heart is that you still cannot have more than 49% mental health. And that's unfortunate. In some areas, the need is greater than 49%. So we do everything we can to pass those surveys when there's a whole lot of mental health, Suboxone use, addiction services. So we can measure it by the reason for today's visit. So if there's an issue for you, you might want to look at that, because every person in for substance abuse has health issues. And if they're coming to see you for flu shots and other things, we can use the reason for visit today, not just the primary diagnosis, if it happens to be substance abuse. So if that doesn't make sense, you ask the question at the end and we'll talk about that some more. Now, only 4 required labs. So hemoglobin or hematocrit was removed and fecal alcohol blood was removed. So that makes that nice. Now, if you still have any of those old, I'll call blood cards or hemoglobin supplies, and you're not using them, get rid of them. Because if we find them and they're expired, you're going to get cited and you don't want to do that. If you're using them, that's fine, then they would be in date. Okay, that's the basics of what's new from my world of compliance. There are lots of new billing things, and I'm going to tell you that's where you go to Elizabeth Burrows and her gang there for those kind of questions. So, issues on survey. When the manager is out, should be a comma there, staff should know where everything is stored. I put that in almost on a slide that's alone because it's an issue. Those of you listening may be management, and you happen to have a sick child, or you're sick yourself, or you're on vacation and we show up, or any surveyor shows up, and all of a sudden they can't find things, all that hard work you did, and they can't find it. This is not uncommon, and that's why I'm putting it there. We want you to share your knowledge. Make sure everybody in the clinic knows where things are stored as appropriate. And compliance is a team sport. There's just no one person that can keep their eye on everything. And when that one person's out, like I said, we've had some really tough issues. One recently, they couldn't find any examples of any exercises the clinic did for emergency preparedness. Oh my goodness. We all know they did it. They know they did it, but there's no, and if it's not written down, it didn't happen. If we can't see it, it didn't happen. Now you have till 5 o'clock till we leave to produce the evidence, but sometimes you might be in Mexico or some other lovely place for vacation, and we can't get a hold of you. So please, things go sideways very, very quickly when the staff can't find them. Your name, another issue. Does it match what you told CMS you were called? Now, if you're an initial survey, we look right away, it matches the 855A or not. If you've been around for a while, has anything changed? Go to QCOR, that's qcor.cms.gov, and look up your clinic either by your name or by the CCN, and you'll see what CMS has in their records that you're called, and just make sure it matches what's on your door. Are your clinic hours posted on or near the door of the clinic? Very, very important because it's required, and that's a reportable thing. Now, if you have issues and you need to change that, just report it to the state. If you're with an accreditor, report it to us or another, and then we all know you're not there on Thursdays anymore, or Fridays or Mondays, whatever the case may be. Just make sure they match. Medication management is a huge issue on survey. And this is a very robust policy. Are all the drugs secured in the clinic? Are they stored according to manufacturer's instructions, i.e. refrigeration, or not? Are they delivered in the clinic? Are those drugs delivered in the clinic properly documented in EMR? Do we have the right patient, the right medication, the right dose, the right route, right time? And most importantly, that I didn't add, the lot number of the injectable. That can save you a deficiency. If for some reason somebody didn't write that 28-day date on that vial, we know when it was used and you could maybe not have a deficiency. Is every person dealing with drugs trained on vials? We're going to hit that more in a minute. Is everyone trained on safe injection practices? We had a young MA not 2 weeks ago who never wiped the top of the vial off before she put the needle in to draw up the medication. Was she ever trained? Didn't she know how bad that is? Bacteria on that surface. And is there a proper recording for receipt and disposition of scheduled drugs? So all scheduled drugs must have a log. That would mean Mr. Smith's vial of testosterone. Every dose needs to be given to Mr. Smith and no diversion, and that's why that's required, because it is a scheduled drug. Pre-filled syringes are never allowed. Once that vaccine is inside the syringe or any other medication, it's impossible to tell which it is, which can lead to medication errors. As a nurse, I would never give a medication somebody else drew up because I'm responsible. I'm administering them. So let's make sure that we don't use this process for flu shot days. Bacterial contamination can occur in the plastic syringes. There's no study that says how long they're good. Today would be the end of it, for sure. And we find them. We found that. That's a picture from a survey. When you buy them in a glass syringe and they come without a needle, they're good for as long as the manufacturer says. They're in glass, not in plastic. It's kind of like all the data we're seeing on us drinking out of plastic water bottles. Much the same as that plastic in that syringe. So there's no data for that. So let's not do the pre-filled syringes. For the equipment in your clinic, is every piece in the clinic on a list? Is there a system for knowing what needs mechanical checks, biomedical checks, and what needs electrical safety? You don't have to pay a biomedical engineer to make sure the wires aren't frayed in your clinic, but you do have to have them all inspected once a year. So your equipment is maintained in accordance with manufacturer's recommendations. If you look at a piece of equipment and you don't know and I don't know, the only way we all know is to look up the manufacturer's instructions for use. And that's really important. Now, for the annual checks, you can have them stickered. You can print a report to show the person, the surveyor. Either way is fine, but make sure that that is happening once a year. Now, here's our vials. So we're still seeing this. Let me tell you a little story. About 5 or 6 years ago, a clinic in, well, I won't tell you even what state, had a single dose vial with a 28-day date on it. One vial in a clinic where there were 50 vials. It was a very big clinic. Surveyor called in to see what he should do because that's egregious. There's no preservative in a single dose vial. And I said, question everybody independently about this. And he called back later and said, oh, everybody agreed it was egregious. Must have been a one-off. And I said, let's make it standard level. And that way the clinic is required to prove to us that they retrained the staff about single dose vials. So we did that. We passed them. 3 months later, CMS came back to us and said, nope, you have to fail that clinic. You don't have any way to know if that drug was safe or effective with a 28-day date on a single dose vial because it is has no preservatives. So from that day on, one single dose vial and you failed survey. And it happens. And we stand there with the surveyor and the clinic manager and the little MA, and I don't mean to pick on them, but they have typically the ones, says, I never knew there was a difference. It just happened a month ago with 4 vials, all dated. She never knew. So how long has that been going on in that clinic where we perhaps unsafe or ineffective medications? So please, please, please don't assume everyone in your clinic knows this right now. Some of you are rolling your eyes. Yeah, we know that. Well, I'm going to tell you, we're still citing it. Not as often as we were, because I've been preaching it for a couple of years now, but it's getting better, but not good, not perfect. So train them. What is the difference between a single dose and a multi-dose vial? Multi-dose vial, your policy should say open and date for 28 days, unless the actual vial expires before then. Store them separately, whatever you need to do to make sure that this does not happen again, and certainly for the patient's sake, but you also don't want to fail survey. So multi-dose vials, 28-day dates, single dose vials, never dated, never, never, never. And some things like lidocaine, once in a while they'll come shipped in a big vial and you can't believe it's multi-dose, or rather it's single dose, but it is, and it happens. I don't know if that's supply chain or whatever. It happened a lot during COVID, but now I don't know why it would happen, but make sure you teach people, you pick up the vial, you read the drug, you read the dose, you read the expiration date, you read single dose, multi-dose. In my day, we even held it up to the light to make sure nothing was floating in there that shouldn't be. So I don't see anybody doing that any longer, but that was the truth when I was nursing many years ago. So this clinic had this problem and they figured it out before survey, and they had this little test for a month where no one was allowed to put a vial back in the closet. They had to put it in that red bin, and the nurse would check several times a day. And they found their culprit and re-educated that person, and so they passed survey just fine. So staff education, find out what they know, and then train, and document that training always. Anytime you train, you should be documenting it for your survey to prove that you are doing the training. So this is a great little tool, and it is free. And there's the gohcl.com, and it is a 28-day counter for the whole year. Now I just put in today's dates. So if you open a vial on today, what is today's date? May 27th. On your date, you're going to put June 24th as the expiration date. It makes it so much easier because you don't have to think, what's 28 days from May 27th? It's June 24th, and who could come up that quickly? So I would encourage you to go and download this. If somebody wants me to mail it out, I can send it. I have a copy of the whole year for this year. There's probably other places to get it, but post it in your med cabinet, and you'll never have that problem again. It makes life so much easier. What does your medical director do? Well, first, he must be licensed in the state where your clinic resides. This is a reportable event. That goes on a CMS 29 to the state and to your accreditor, if you're under an accreditor, which is always better because you're going to have regular surveys and make sure you're never going to risk to lose that number. There is no waiver for the medical director. CMS provides a reasonable time to come back into compliance. So you just document what you're doing to find one, but there's no waiver for not having one. Yes, you can pass survey. I would recommend that you document everything and what efforts you have. You can get a locum medical director. You cannot get a locum NP, but for the NPs, you can get a waiver. So we'll talk about that more in a minute. And there it is. An existing RHC may request a waiver from the state after 90 days for 1 year on the loss of your NP or PA. Now, we just had one in New York, and they were, the state that is, were wicked on the documentation that the hospital did as a provider-based clinic during the 90 days before they asked for the waiver. So the state said to them in writing, what have you done to find one before we grant you a waiver? And they wanted the documentation. How many did they interview? Where did they post the job? How many did they turn down? Et cetera, et cetera. They wanted heavy documentation on that. Not all states are like that, but it's still, you do need to document. Then at 90 days, if you haven't found one, and that happens, especially in rural areas that are just over the edge to get to a city where somebody could make more money, understandable, takes a little longer. But after 90 days, or at 90 days, you email the state survey agency, notify the accreditor as well, because we'll help you track the 90 days. And then you ask for a waiver. And don't think we've ever had one that was denied to get a waiver. So you will get one for a year. And during that time, you're documenting everything. So in case there should be an issue. Now, your NPPA or a midwife is available to furnish patient care services at least 50% of the operating hours. So all time spent in the clinic counts toward the 50%. That means admin time. Also time spent in the patient's home or in a SNF or doing sleep bed rounds in your hospital. All that counts if you're on the line, but you must document it. When the clinic has a midwife or an NPPA that's there all week, we don't even worry about this. But if you're close, then you need to be documenting that time so you don't have an issue with survey. Of course, infection prevention is a large topic. We don't want any infection spreads in the house. So are you appropriately monitoring your housekeeping? This is an OSHA rule that you have to have a schedule for how that clinic is cleaned. What does it look like? Is it paid for by somebody else? They're coming in to do it. But beyond that kind of heavy cleaning, what's the housekeeping for tables between patients, for exam rooms, for equipment, all that? Is the staff washing their hands? Like I said, I've been a nurse for many, many years. And we're still talking about hand washing and still citing it, particularly providers in between patients, and they tend to walk by that alcohol-based gel and it just takes a second, but they do need to wash their hands. And your staff working with patients, before and after gloving, all those things. Are single-use devices used only once? No sterilization of anything that's single-use, not just those vials, but other pieces of equipment in the clinic. How are the clinic surfaces cleaned? Does the person know the wet or kill time? That's really very important. We'll talk about that more in a minute. How do you dispose of your medical waste? Is it in a room marked biohazard and locked so no inquiring minds can get in there, along with your sharps containers? Are you certain that instruments are sterile? When you hand an instrument to a provider, do you know it's sterile so that they can be confident about that? And is your staff trained on point of care devices? All feed in to that all important infection prevention policy. So when we see one of these sterilizers, we groan because it's about a 90% fail rate. And here's what we're going to do. And I will suggest if you have a tabletop sterilizer in your clinic, that you would pull the manufacturer's instructions for use for the M7 Speedclave Ritter, print it, and compare it to your policy. Are you properly cleaning, spore testing? Are you sterilizing instruments? For sure. And we find that they don't match. It's almost inevitable. So that's a heads up to you. If that's an issue and you have one of these, let's make sure we're handing the provider a sterile instrument to do a procedure. Let me back up on that one because I don't think I have a slide on it. If you're transferring your instruments to the hospital for sterilization, what's the pre-clean look like? What are you transporting them in? Is something that doesn't leak-proof? And what are you accepting back? So you need to know the hospital's process so that you don't accept what is improperly sterilized. But if you don't know their process, you wouldn't be able to know that. So you need to get with the hospital on that one to make sure. Should there be dates? Should there be hash marks? Are there spore loads in there? Load logs, all that. And what does it look like? Medical record review. So we have multiple states listening today. If your state is silent, and many are, with 50% of the states having autonomy for our APs, then you must determine how many and how often. If your medical director is quite comfortable with that nurse practitioner's practice, then maybe you only pick 5 a quarter. If the state is silent, that's acceptable. Don't lock yourself into a tight corner and say, we're going to do 5 a week, because you're too busy, you're not going to do it. Pick your number. Now, if your state has a number or a percentage, then it's noted in your policy and we can see evidence of that. And so there must be a policy either way, even with autonomy, on how many records he will review. Because even with autonomy, it's still in the federal regulations that we do chart review. And how do you document that? How do you show it's been done? How do you document collaboration on those chart reviews? Did they ever talk, even though he wrote something? It's really a good idea if you have a log, and it's, let's say, 5 charts a quarter, that he signs it and she signs it, for he, she, whatever. The MD and the NP sign that form, and then it's done, that we know there's collaboration. At least that's the only way. We really have a hard time finding that if you didn't write it down some way. Be careful about putting your policies so rigid that you've locked yourself into a tight corner. We see a lot of clinics that call for an annual consent. That's absolutely fine if that's your process. There is no law that requires that. You may have a Medicaid that requires that, but basically no federal law that requires an annual consent. So if the surveyor reviews files and there is no new consent in 25, you're going to have a deficiency. We're going to look at 20 files. 4 didn't have consents this year, but they had them. You'd have a deficiency. If you didn't have that in your policy, there would be no deficiency because they have a consent. So be careful about that. Once in a while, we're still running into a clinic that says annual evaluation. It is biennial by law. Is it a good idea to do annual? Of course it is, because you want to look at your business and see where you're going and what we've done. But if you put annual in the policy, then we have to see an annual review. And if you didn't do one, then again, you have a deficiency. So a lot of these things are avoidable just by how you word it. These are the policies that you need. Keep them organized. You can review a few at each staff meeting, but in the end, every policy needs to be reviewed every 2 years. As I said, keep your policies simple. Don't lock yourself in a tight corner. You can always do more. You must have patient care policies, the biennial review of policies by that advisory group. Who's that advisory group? An NP or PA, an MD or DO, and an outside person. Now, that outside person can be Miss Melissa Jones, if she's trained, and I don't know the answer to that, but it certainly can be Elizabeth Burrows, if you wish. If you're an independent clinic, your consultant can be that person. If you're provider-based, it's typically somebody at the hospital, the quality control nurse, the head nurse, all kinds of people, the accreditation specialist, anybody that's qualified can be that person. There is a signature page in your policy book, whether it be electronic or paper, that says our policies were reviewed on this date, and it's signed by at least those 3 people, and you're good. And as long as that date's not more than 2 years old, you're in perfect shape. Then there's a pharmacy policy, and that's a big one. Your storage, your handling, dispensing of drugs and biologicals. I would recommend you have a policy on how you handle single-dose files and multi-dose files in that policy. Of course, you have emergency preparedness policies. We'll talk about that more in a minute. Your health records. What is your policy about how quickly a provider has to sign off on the record? Is it 24, 48, 5 days? What is it? So we're reviewing 20 files, and your policy is 5 days, which is fine. A little long, but it's absolutely fine. It's your policy. And we're looking at files from 2 weeks ago, and they're not signed off. You're going to have a deficiency. So you see how so many of these can be prevented. HIPAA. What's your HIPAA policy? Obviously, we all have a HIPAA policy on how we prevent any leaks of PHI. What is your scope of services provided, and what do you refer? You know, this is still in the law. I call this your mission statement. We provide primary care, or you could call it outpatient healthcare services from birth to death, and we refer. And throw a few things in there. What do we refer? Colonoscopies, mammograms, surgery. You know, those things we don't do in our clinic, and you'll be fine with that. What are your lines of authority? We'll use an org chart for that. We don't need to see a special policy on that. How do you manage your equipment? We've talked about that. How do you prevent the spread of infection in the clinic? How do you hire, train, and orient your staff? So annual training and on hire. For provider-based clinics, it's very unusual. Matter of fact, I've never seen it be different than your hospital. So all you need to do is make sure the hospital hiring training policy says in it that it covers all their entities, or maybe the name of the clinic by name. Either way, it's covering you, so you don't have to write another one. And some of the HIPAA policy would be the same. Some of them are very global in their scope. Infection prevention, if we have a hospital policy, we're into hospital operating rooms and central supply and all the rest of it. Gets a little long, but it could be, but it's best if you had your own. And then last is quality improvement. What are you doing to make sure that you're doing the job well? Are you reviewing charts for completeness? We recommend 10 charts a quarter, and you can use those charts as well as your physician review charts in a file for your program evaluation every 2 years. Keep your policies simple and let them work for you, not be a hindrance to you. So the labs are for immediate diagnosis. All 4 required tests. Now we know we don't have the other 2 any longer. All the reagents are in date, and your CLIA is current and posted. And the CLIA has to have the correct address. That's very address driven for the CLIA in your clinic. Make sure you apply early. as early as they allow. They're not good about being quick about sending the certificate out. If you can show that you applied and it's paid and there's some kind of receipt or something, and your CLIA is expired hanging on the wall, tuck it behind there. We'll honor that because they are very slow about sending the new certificates out. Now, you must be able to handle a medical emergency in the clinic, as I mentioned in the beginning, whether it's just a family counselor there or an NP, you still have to be able to handle that medical emergency. So you have a policy on how we handle common life-threatening injuries, acute illnesses at all time the clinic operates. Most common, of course, is a code, not common, but an awful one. And we have had several recently in the clinic. So you make sure you have that. So you have a supply of emergency drugs in a portable box, the contents of which are listed in the policy. The reason for that is, if you remember, and the law still says all that list of drugs that you have to have in there, no longer true. And when the CMS gave, that was a gimme on CMS's part, when they gave us that freedom to let you decide what's in your emergency box, which is a good thing, it had to be verified and approved by the medical director. So that's why we like you to print that list from the policy, put it near the box, and we just compare the two, making sure that none of them are outdated, of course. Does your box match your policy? That's going to be important. And how did the RHC come to decide what's in that box? It was supposed to be a collaboration between your medical director and your non-physician providers. And make sure you're checking that box regularly for outdates. Now, the compliance team clinics must have 1 tank of oxygen, and that is really how you handle a medical emergency. So we're quite surprised that the government doesn't have that in there, but for our clinics, we want you to have at least 1 tank. Actually, I think not been in a clinic that didn't have 1 tank. In your patient records, a common deficiency is for a minor patient, the consent. If I bring a child in, it's going to be Kate Hill, grandmother, and you all know me and you know I'm allowed to bring that child. If somebody brings a patient in and says, friend, do you know? This is to protect you. Is there a relationship to patient on the consent form? And then we don't go investigating beyond that, but you should. You need to know, do we have permission for this guy to bring this child in? What's happening here? That's for your protection. In the medication area, is the EMR capturing the med, the lot number, the route, administration, dose, and date? Abnormal labs. So this is, CMS has been on a tear about this lately. So for abnormal labs specifically, have the results been reported to the patient? So the minute we see an abnormal lab, an A1C of 15 or something, the next line should be patient notified. And what did we do? We're bringing them in to retest, we're putting them on a medication, we're calling them in for a visit, whatever it is, patient notified is what's critical. And then what instructions are given to the patient. If your policy says normal labs are not called out, you won't get a deficiency. But does your policy say that? Does your policy say if my A1C is 4, you don't need to call me? I don't know. It's your policy. Just make sure it's reflected in your policy what your process actually is. If it's an abnormal lab, but it's, how do I say this? It's a better abnormal than it was. Like the A1C was 15 and oh my goodness, the A1C is only 10, but that's still abnormal. Well, there should be a note. Did you need to call the patient? I can't make that judgment. Your NPs will make that judgment, but there should be a note, abnormal A1C, but better, keep to the same regime or something like that, doing well, you know, that kind of thing. And then lastly, in the summary, is there a documented summary of the visit with instructions for the patient? What happened here today? At the end of the visit, see in a year, see in 2 weeks, here's some labs, do these before you come back. What does it say? There's no pattern to that. It's unique to the patient and the provider, but it should be there. For personnel, this is what makes a good personnel file. A W-4 for at least that 1 employee, NP or PA, that didn't go away. We hope that would go away, didn't either. I-9s for your employees, a CV, an application, or resume, and that is depending on their level of hire. By the way, some states look at all this, some do not. We tend to, so we're going to go through this list. Your orientation and training on hire, and annually, how do you document that? Sign standards of conduct. How can you evaluate anybody if they don't know what you expect of their conduct? Their licenses, of course, we check every license of every person for sure. The OIG exclusion list verification. So for the federal government, if you bill Medicare, you cannot hire anyone who's on that list. So once a year, and there are a few states that have gone to monthly. There are very few, but there are a couple out there. You must go to www.oig.hhs.gov, plunk in their name, and it says no results. You print that and put it in their file. If it says verify next to it, then you must go back in with that name, either a middle initial or a social security, whatever will clear them, and then it'll be no results and you're good. Something like Michael Smith is a very common name, and those kind of common names do pop up because there's one somewhere who's been convicted of Medicare fraud. This is all about fraud, waste, and abuse. Your annual performance evaluations. We don't look lower than a year, but if you should have a policy, but it's your policy. We do a review at 30, 60, 90 days. What is yours? Everybody's different on that. Now, background checks will always be best practice, always. But if it's not required by your state or by your organizational policy, we can't require it either. So again, it is best practice, but so much of the time in rural, it's a local person everybody knows forever and they don't want to do a background check. And that's up to you, but make sure it's not in your policy if that's the case. Hep B, for all those working directly with patients. If someone had their Hep B series long ago and they can't remember to prove it, have them sign a declination. All we want to know is everybody's safe from hepatitis. TB evaluation requirements, that's going to be screening on hire and annually. And then BLS. Now, this is a compliance team requirement that everyone licensed or certified has at least BLS. I get the question a lot, if I have ACLS, do I need BLS? No, you don't. You're advanced. You don't need the BLS. You're way beyond the rest of us with just BLS. And that's it. If you're not with a compliance team, that is a best practice. You are rural and you must handle that emergency. And you may be 20 minutes, 30 minutes away from an ambulance. You also may be in the hospital building. So again, all those things. By the way, let me say this on that emergency drug box. If your clinic is practically in the hospital or across the street, your box may be much lighter than the box down the road a piece where they have to be administering some drugs a long time till that rig gets there, okay? So it doesn't matter. It's your box. What do you need at your location? And that's why it was wonderful that CMS finally gave the freedom for us to do that, for you to do that. This is another one of those compliance team things, and I want to tell you, I've been saying this because it's our owner, Sandy, who's a nurse, and she doesn't want FinPrep in that drawer under mom. And you can see it's wicked stuff even if you breathe it. Well, I've been saying this for 13 years, and not 2 weeks ago, a nurse practitioner on a call with me said, I saw this happen. Mom was on the table, a toddler was in the room, he reached in and got one of those FinPreps and opened it. She caught it in time, he didn't breathe it. It's formaldehyde, for crying out loud. So that's a compliance team thing. We don't think it should be in that drawer. It does not need to be locked. It needs to be put above counter level in a cabinet, then she can grab one and sit down. Again, it is really wicked stuff. Protective equipment to keep your staff safe. We had a nurse get burned with ladling liquid nitrogen from that big tank into a small container to take into a room. So we require the heavy duty gloves and goggles, and that should be anybody that does that sort of thing. You need to look around your clinic with eyes that see what's an issue here. If you have a 5-gallon drum of disinfectant that when you push that pump down, it splatters, well, then require them to wear goggles when they're protective glasses when they're using that. You know, it's really not, you can have the sheets to look it up what to do, but if you know something does cause problems, then have everybody trained on it right there. So your OSTA poster needs to be your state and the right year, 2025, almost half over yet. I can't even believe that. Another month it will be. It's hard to believe. And the proper PPE in your clinic, whatever you need, obviously gloves and masks and whatnot. And then, like I said, safety data sheets. Yes, it's good to have them. You can have them on your intranet. You can have them on the screen somewhere in the clinic, or you can have them printed. That's your choice, but you do have them for issues that could occur in your clinic. This is the exam table I wanted to talk to you about. What is the wet time of that disinfectant? If you wipe that table down with disinfectant that kills Hep B and HIV is not expired, right? And you read the wet time. The wet time could be 30 seconds to 3 minutes, as we found with the different varieties. It must be health grade disinfectant, not something you buy at Walmart. And if the wet time is 3 minutes and you if you wipe and pull the table paper down right away, all it's going to do is suck it up in the paper, and we've not accomplished anything. You might have to change your routine to go wipe, go get a patient, come back and pull the paper down. Everybody wiping down papers should know the wet time of the disinfectant they're using, and to make sure the container is not expired. On the right is a table that cannot be disinfected. Can you pass survey? You bet. You're going to duct tape it. I said it, duct tape it, and show us the work order to get that repaired. Who knows what's growing in there? We can't disinfect that table, but you can get it repaired. I'll tell you, car repair places, leather places do a wonderful job and leave it match the color. You don't need a new bed, but show us that you are on it and you're preparing to fix that table. Now, in the clinic, all chemicals back here, all biohazards, all sharps, and all medications are locked. I don't care if they're keyed or coded or swiped, whatever, they're all locked. I get asked about this all the time, and I still haven't gotten a new picture. These are wipes. They do not need to be locked, so you don't have that. Now, the oxygen tank, I would rather that be near that emergency medical box so that we grab it and go. And of course, oxygen is always on its proper tank or secured. But this is a small clinic with lots going on in that room there. Sharps containers are mounted on the walls, so we're not enabling anybody to help themselves to dirty needles. This is not an acceptable sharps container in any patient area. If you have one like that in your med room, of course the med room is always locked, that's fine. But mostly these are seen in operating rooms. Now, red bag containers are not required. Red bags are for bloody, dripping, infected dressings, not Band-Aids. And so you could have one and that's fine. This one is red, though it does not need that biohazard sticker. You'll have others that are white. All it needs to be is covered, and you could have a few spare red bags in your container if you need them and be fine for the use of those, but there's no requirement for those. Now, the biennial review of the clinic is every 2 years. There's no waiver for this. Look at the date. This is your second assignment. So if you have it sterilized, you're going to look for that process. The next one's going to be looking for the date of your last biennial review. Make sure it's not more than 2 years old. If that's not done, you just failed survey if they walk in the door, okay? So please, please, please know the date of your last one. And there's that review sheet. Who signed off? Those 3 people, MD or DO, and PPA, and an outside person. And is it within 2 years of the last one? So this is a very important evaluation required by CMS. Now, emergency preparedness, of course, is a big lift for all of us. We do want to be prepared, but it is taking a fair amount of work on your part. You're going to do, first off, a risk assessment of what could happen in your clinic, both power things, natural disasters, so many awful tornadoes lately, emerging infectious diseases. That's your choice if you choose to put that in there. You certainly know well enough about it right now. Any disruption of services, the clinic closure, all kinds of things could be in your risk assessment. The risk assessment must be reviewed every 2 years. How do you document that? Is it just an initial at the bottom of the page or signing off on the policy? Find a way, because it is a requirement that you review it. Now, what's changed? Well, maybe the weather's changed. That's not really likely. What's changed is they built a fireworks factory down the street, or the highway just went through and we might have an accident that's close. Whatever it is, make sure that you're evaluating if anything has changed. You must exercise one of the items listed on your HVA, unless it's an event. If you have an event, all bets are off. Never let an event go to waste. Write it up, and I'm going to show you how in a second here. But if you have to do one exercise a year, and you do, if you didn't have an event, use your list, because if you're not, like I sit in Pennsylvania, and I don't have earthquakes here. Well, why would I do an earthquake drill? Praise the Lord, we don't have tornadoes either. For those that you do, it's just a frightening thing to me. But at any rate, you would do a tornado drill, of course, but not something that's not on your list. If you're in Texas, you might never do a hurricane, unless you're in South Texas, a hurricane drill. Why? right? So that's the point. And you shouldn't exercise the same thing year after year. A code, a 911 is not an exercise. It's what you're supposed to do. So we don't count that. And a fire drill either. I wish every clinic would do a fire drill every year. The only place we've accepted the fire as a risk assessment is Northern California, Oregon, Washington, where this happens, unfortunately, a fairly regular basis. And they need to know to be prepared for that. Your communication plan, is it complete? Listen, I hate to see anybody take a deficiency for this. It's a bunch of names and phone numbers. Everybody that works there, the local, regional, state, tribal, federal emergency staff, another RHC, all those things are in there. If there's no tribal within 50 miles, make a note. There are none, no tribal clinics. And you don't need the permission for another RHC or an FQHC, just write their name and phone number down there. You must address volunteers. If you think of the surveyor as having a checklist, and volunteers is there, and you didn't talk about it, you get a deficiency because you didn't address it. We know, I've yet to see a volunteer in a clinic. Maybe somebody's husband might help out on occasion, an NP. I just had that happen actually. But all you need to do is say, your clinic has made the decision not to utilize volunteers, and you're good. And of course, you must address how refrigerated medications are handled in a power outage. This is critically important. It should be part of your EP. The power goes out 9 o'clock Friday night. You're all home for the weekend. You come back in Monday. That power didn't come on till Sunday night. How do you know those drugs are safe? You must be able to answer that question. And then the training, have a log to document that the staff was trained and there's signatures to show that training, and it's dated again every 2 years. So on the exercises, you must participate in a full-scale exercise that's community-based, or when that's not accessible, an individual facility-based. They're really lightened up on community-based. It's so hard to get. First, you have to pay the people. You have to take a whole day. It takes a whole lot of planning to get a whole community-based exercise. If you can get one, wonderful. But if you have a clinic-based exercise, you will pass survey. So if 1 year is full-scale exercise, and the other is a tabletop. And that's how it goes in general, unless there's an event, and then that takes the place of either of those. You must analyze the response to the exercise or activation of your plan. If the power goes out and you had to actually move drugs or whatnot, write it up. It's an event. And what happened? And did we do it right? And so the exercise must be one of your hazard assessments, as I said, and not assessing the same thing year after year. We're trying to find the gaps in your program so that when something does hit you, you're prepared. So the analysis is really important. There's a form, if you Google CMS AAR, that's After Action Report, this will come up in a real wonky document, but this is the Word part of it. And you just write your analysis based on this. ABC Clinic had a power outage on April 19th, 2025, and the purpose of this report is to analyze that, how we handled it. Do we do well? And we can build upon. What didn't we do so well? And it took forever to get the drugs moved because the data miner didn't text the right person, whatever. What could we do to make it better next time? And then review that report with your staff and the assignments given and an attendance log for all exercises or events. There's an attendance log. Who was trained as a result of this event? If you are a manager and you go to the hospital for an exercise, you must then, first of all, make sure your clinic is listed in the write-up of the hospital. And number two, when you come back to the clinic, do your own teaching them what you learned up there to effectively battle that emergency, whatever it would be. So in the end, the summary of still the most common deficiencies: single dose vial data, biggie, drugs not locked, the NP or PA not signing off on those policies every 2 years, no analysis of that emergency event, that's really important, not having all your contact information. Again, I hate to see that list because it's just a bunch of phone numbers, really. No documentation of chart review. You say you're doing it. How do you prove it to the surveyor? Very, very important. No outside person signing off on those policies, not abiding by that wet time of your disinfectant, the sign not matching the name you told CMS you were called, and then lastly, expired, and we see it almost all the time. It could be a perfect survey, except nobody noticed that the iota form, the gloves, the Vacutainer tubes, they all have a date on them. So they make sure you're doing your rounds, you're checking all of that. throughout the clinic. So most surveyors will interview staff. Can they articulate what they're responsible for? Obviously, they don't need to know everything. They need to know where to go look. Perfect example. If I ask the NP, what's your sign-off policy on your charts? And she doesn't know because she closes hers every day, God bless her. Well, she has to know where to go get the answer. Oh yeah, I know that's in the policy on charts, on EMR, and I go here and I find it, okay? What do you have to do to evacuate the clinic? Did you ever have a fire drill? So let's make sure we got that. Maybe not just evacuate, maybe to hunker down in place if there's a tornado warning or something like that. And then staff, as I said, should only be prepared to answer questions related to their jobs. And of course, everybody knows about emergency protocols. So deficiencies can be standard level. Well, first of all, there can be no deficiencies. If you work hard and read the standards and know what's expected of you, you can pass with 100%. It happens probably 10% of the time, not often enough, but it does happen for us. But standard level deficiencies means it's not terribly serious. 5 consents were missing. We write it up, you write a plan of correction, and then we're good to go. Condition level really poses a serious threat to patient health and safety. It's condition level, and we have to resurvey you again. And 3 strikes on that, you're out, and you don't have a billing number any longer. So you want to make sure that never happens to you. Okay. Sometimes it's a matter of degree, like 15 patients had no consents out of 20. Sometimes it's right on the line, and the surveyor will say at your exit interview, this gets reviewed by a 3-panel group because we want to be consistent, and we're going to have a big discussion on should this be a pass or a fail. So there's some interesting discussions on those, but they sometimes can't tell you which way it's going to go, but they will tell you what the deficiency was. So if you have to write a plan of correction, and CMS reads these, believe me, the process or the lack of process that led to the deficiency is how you start off. So let's take expired medications in the clinic. The monthly monitoring wasn't going real well, so that's what led to it. We fell off the track about that. What action are we taking to correct the deficiency? We're going to monitor those drug closets every week for 3 months, or every week for a month, then every month, some kind of pattern to show you're looking to keep it corrected, no matter what happens in the clinic. And then the title of the person responsible, no names ever in a POC. You won't find any names in our statement of deficiencies. It's nurse number 1, clinic administrator, MD, whatever, because they are discoverable and we don't want anybody seeing the names. There is a signature at the bottom of the administrator signing that plan of correction. So all surveys are unannounced, so be prepared. Always be company ready. Managers, share your knowledge. I can't say that enough. Most surveys we take between 6 and 8 hours, depending on the size of the clinic and the number of providers and staff to check. Easy access to policies, personnel records, medical records. We don't touch your EMR. We sit down next to you and we'll say, pull a chart up from nurse practitioner Susie from last week, and she'll pick one. So they're very random. And then in the exit interview, and then know exactly what they found and hopefully nothing. So with that, I'm going to turn my camera back on so I can talk to you, and I'd love to entertain some questions.
Can you hear me now?
Questions are free.
Hello?
There's my email address. You won't very often get me on the phone, but you can email me, and I get questions all day long. I'm happy to help anybody.
Okay, well, in the chat, I'm not seeing anything. Hopefully you can hear me now. I think it might be working. There actually is a random question on the Billing 101 webinar. I apologize to everybody. We needed to reschedule those. So if anybody is looking for the new registration link for that, we will send those out. Again, we had to reschedule the billing portion of this. We definitely didn't want to confuse regulation with billing, so we split those in two. But sorry about that. I will resend those registration links once all the billing are rescheduled. But Kate, actually, this is the first time that we've not had direct RHC regulation questions sitting in here. I will have to say that's
Well,
a first.
that tells me that Burrows has these people prepared, and you've got all this, and you're doing well, and that's good. It is
Okay,
unusual to not get a
you're
question,
great.
but
You're great. Well, as I give you your thank yous, I'll keep the chat open if anybody thinks of a last minute question. But we of course thank you very much, Kate. A heartfelt thank you to you and the compliance team. You bring valuable information always. I've watched you over 10 years in webinars, and the opportunity that I can get to get you on one, I value that. You're a very trusted resource in the RHC community. I really do appreciate your time, as well as everybody else
thank
on
you.
the call today that joined. Very appreciative. And let me check the chat one more time. No, I don't see anything new that's came in. So, yep, like I
Okay.
said, we'll send out new registration links for the additional webinars, and stay tuned.
Okay. Thank you so much. Have a great
Thank
day.